Hi, class, and we are continuing with week 10, and chapter 19 is focusing on Z codes and how they explain why the patient is being seen. These codes capture factors that influence health status, even when the patient isn't sick in the traditional sense. Think about preventive visits, and it's preventive, not preventative, which you have to learn is part of the coding language. Screenings, follow-up care, organ donations, and antibiotic resistance. By the end of this chapter, I want you to feel comfortable choosing the right Z code to support medical necessity and to tell the story of the encounter, of course, clearly and succinctly. By the time you finish, you should be able to abstract details about preventive services and use Z codes to show why those services are medically necessary. You'll determine why providers order early detection tests like screenings, even when the patient has no symptom. You'll see how to report encounters related to genetic susceptibility, such as carrier status. And also, you'll identify the reasons for observation services so you can choose the correct Z03 or Z04 codes. As I go through the examples, I want you to keep asking yourself, what is the reason for this visit? I also want you to apply the official coding guidelines for aftercare and follow-up encounters, especially when the acute phase has ended but care continues. You'll evaluate services related to organ donation and decide which Z codes show the medical necessity for those services. You'll also learn how to flag antimicrobial drug resistance with Z16 codes. And then finally, you'll practice using the Z codes as either the first listed code or an additional code depending on the encounter. Before we jump into the codes, I want to ground you and ground me in the vocabulary. Preventive care is about keeping disease from developing in the first place. Screening is testing a person with no signs or symptoms to catch diseases early. Abnormal findings are test results that suggest a possible condition. Carrier refers to someone who can pass on a disease or an abnormal gene, even if they're not sick. Then we have transplant-related terms like autologous, allogenic, isogenic, and xenogenic, which describe where donor tissue comes from. This is going to be very much applicable when we go into ICD 10 PCS in the winter term. So you're going to learn about the autologous, allogenic, isogenic, and xenogenic or xenogenetic terms. I'll keep tying these terms back to specific Z codes as we go. So the section is about preventive care. Preventive care. I want you to think of Z codes as the justification codes that explain why we're doing vaccines or routine exams or counseling when the patient doesn't have a current complaint. Preventive services often show up in outpatient and primary care settings. As coders, we need to pull out the type of preventive service and the patient's status to support coverage and medical necessity. Preventive care includes services designed to stop a disease or injury before it starts. A classic example is Z23, Encounter for Immunization. When a patient comes in for a flu shot, a pneumonia vaccine, or childhood immunization, I'm thinking Z23 plus an appropriate procedure code. I'm not coding flu, I'm not coding pneumonia, because the patient doesn't have that condition when they come in to see the provider. The visit is about prevention. So when I read a note that says, patient here for routine vaccine, my brain immediately goes to Z23. Okay, so now I'm going to shift into early detection. This is still preventive, but is slightly different in focus. Instead of vaccines, we're looking for disease early in people who feel fine. annual physicals, well child visits, and specific screening tests fall under this section. My coding question here is this screening an encounter, or is there already a known problem? A screening happens when the patient has no signs or symptoms and the provider is looking for a hidden disease. For a general adult exam with no abnormal findings, I want to use Z00.00. For a routine child health exam without abnormal findings, we're going to use Z00.129. For specific screenings, I might see codes like Z13.22, encounter for screening for metabolic disorders, or Z13.820, encounter for screenings for osteoporosis. When I see a note that says annual physical or routine well child visit, I ask, why was this routine? Is there anything abnormal going on with the patient? I want to clearly read through the notes and make sure there's nothing hidden in there. So, like, is this an annual exam, or is this a problem-focused visit? So, did the patient come for their annual and they're not experiencing any signs or symptoms, any complaints today? So in that case, it would be appropriate to code that Z00.00. Sometimes these routine exams uncover abnormal results. Abnormal findings are test results that suggest a disease might be present. In that case, the screening or exam code changes. For example, Z00.01 is for general adult medical exam with abnormal findings. Z01.411 is for a general or routine gynecological exam with abnormal findings. When those abnormal findings are documented, I not only switch to the with abnormal findings exam code, but I also add the codes for the actual condition when they are confirmed. And what this does is it tells the payer that we found something and this is what it is. Next, I'm introducing genetic susceptibility. These encounters aren't about an active disease, they're about risk. Patients may be seen because of family history, they might be a known carrier, or concern about passing on a genetic disorder. Z codes in this area help explain why genetic counseling, testing, or follow-up is medically necessary, even if the patient isn't currently displaying any signs or symptoms. A carrier can mean two things. It can be a person who is infected but not ill and can still transmit the disease. It can also mean someone who has an abnormal gene and can pass it on to their children, which increases the child's risk of a disease. In both cases, the patient might look healthy right now, but there is a clear reason for genetic counseling, testing, or monitoring. When I see this language about carrier status or genetic risk, I think Z codes for genetic susceptibility and about documenting why these services are being performed. Now we're going to move into observation encounters. These are situations where the provider suspects a problem but doesn't yet have enough evidence to diagnosis. The patient might not show any clear signs or symptoms, but something in the history or initial assessment raises concern. Z03 and Z04 codes help us report these watchful waiting scenarios and show how observation is medically necessary. If a patient is kept for observation in a hospital, it's because a disease is expected but not yet confirmed, a disease or a condition. These represent encounters for medical observation for suspected conditions that are later ruled out. The Z03 codes cover observation and exam for other reasons. The key idea is that I'm coding a reason for the observation, not a final diagnosis. If a condition is later confirmed, I code the actual condition instead of or in addition to the observation Z code, which depends on the situation and guidelines. And we commonly see these observation visits happen from a patient presenting to the emergency room, and maybe it's not warranted to admit to an inpatient status. The provider, the ER doc, might want to just observe the patient for 23 hours, see what happens, see how things unfold, if anything. And this is when we typically see an encounter observation. So next we're going to focus on continuing care and aftercare. These are follow-up encounters after the active phase of treatment has ended, but the patient still needs monitoring, medication management, or care of a healing condition. Here are some key examples. Z51.81 is used for therapeutic drug level monitoring, cases where the provider is checking where a drug level is within the safe and effective range. Z79.01 indicates long-term current use of anticoagulants, and Z79.811 is for long-term current use of aromatase inhibitors. These codes explain why labs and monitoring are happening even if the patient feels fine. If you have a surgical aftercare, Z47.1 covers aftercare following joint replacement, and Z48.00 is for encounters to change or remove non-surgical wound dressings. Z48.24 is for aftercare following a lung transplant. Pay attention to how these codes explain what the main condition has already been treated, but the follow-up care is necessary. Now we're going to talk about organ and tissue donation. These encounters involve donors, potential donors, and recipients. Z codes and key transplant terms describe where tissue comes from and why this exam or procedure is medically necessary. I want you to be comfortable with these transplant terms. And as I noted, we are going to dive into this very deeply with the ICD-10 PCS codes this winter. So be familiar with these terms. Autologous means the donor and recipient are the same person. The tissue is moved from one site on the body to another. This is also called an autograft. Allogenic means donor and recipient are different individuals of the same species. That is human to human, dog to dog, also called an allograft. Isogenic means donor and recipient are genetically identical, such as a monozygotic twins. Xenogenic means donor and recipient are different species, such as a bovine cartilage to a human, which is also called a xenograft or a heterograft. When I see transplant evaluations or donor workups, I want to look for this terminology and for the supporting Z codes that explain why the encounter is taking place. Now I'm going to move into antimicrobial resistance, which is a big safety and public health issue. Sometimes an infection doesn't respond to standard antibiotics. Z16 codes let us flag that resistance. Code Z16, resistance to antimicrobial drugs, is used as an additional code to show that an infection is resistant to a specific medication or group of medications. I also code the infection first, such as pneumonia or UTI, and then add the Z code. Examples include Z16.10 for resistance to unspecified beta-lactam antibiotics, Z16.11 for resistance to penicillins like amoxicillin or ampicillin, Z16.12 for ESBL resistance, and Z16.9 for resistance to other specified beta-lactam antibiotics, such as certain cephalosporins. When the lab results or progress notes mention resistance to or resistance organism or ESBL producer, I want to immediately think about adding a Z16 code. Resistance means that the particular antibiotic will not be effective against the pathogen. Susceptible, also called sensitive, means the antibiotic is expected to work. You'll see this language in culture and sensitivity reports. The organism resistant to or susceptible to, when resistance is documented and clinically relevant, I add the appropriate Z16 code. If the organism is susceptible and there's no unusual resistance, I don't assign a Z16 code. So I always read the lab comments, not just the diagnosis line. In the Slack section, I'm focusing how we use the Z codes as a first listed or principal diagnosis. Many encounters are driven primarily by a Z code: screening, preventive care, aftercare, observation, donor evaluation, etc. Understanding when a Z code can stand alone versus when it must be secondary is the key to accurate sequencing. In many encounters, a Z code might be the only diagnosis reported, or it might be listed with other codes depending on the situation and the official coding guidelines. Many Z codes can be sequenced based on the facts of the encounter. However, there are about 20 Z codes that are allowed only as first listed or principal diagnosis. For those Z codes, for those codes, the Z code is the primary reason for the visit and must appear first. My job as a coder is to thoroughly read that documentation, decide what the true reason is for the encounter, and then decide whether the Z code belongs first or as a secondary code to support that main diagnosis. So to wrap it all up, I want to highlight the main idea. Z codes explain why. They explain why the encounter is medically necessary, especially when the patient appears healthy or the acute problem has already been treated. We use Z codes for preventive care, screenings, observations, aftercare, follow-up, organ donation, etc. As a coder, I'm responsible for making sure every encounter tells a story, and it's clear and accurate, and it can range from preventive vaccines to annual exams to complex transplant and antimicrobial resistant cases. When you see that a visit doesn't seem tied to a classic disease or injury code, I want you to think out loud, is this a Z code? Is this a situation where I really need to apply that Z code methodology? So this brings us to the end of Chapter 19. Your next steps are to review the official coding guidelines related to Z codes, work through your practice cases, and pay attention to encounters where the main reason is preventive care, screening, aftercare, or observation. As you practice, keep asking yourself, what is the real reason for this visit? Which Z codes can best explain it? Bring any tricky Z code scenarios to our next discussion, or put it on the discussion board, or reach out to me to ask the question. I'm here for you. Remember, I have my office hours on Wednesdays from 3 to 4, and I am available via email. So reach out and have a wonderful week. Enjoy Thanksgiving if you're doing anything special. I hope you have a wonderful Thanksgiving with your family, and let me know how I can help. Take care. Bye-bye.